to manage critically ill patients with neurological and neurosurgical conditions. It's a wholly online, one-year American Association of Continuing Medical Education accredited fellowship. Physicians with critical care interest, intensivists, anesthesiologists, emergency medicine, family or internal medicine are qualified. Neurologists and neurosurgeons are also highly encouraged to join the fellowship to gain comprehensive, high-quality, well-structured education in neurocritical care. Fellows are expected to be able to lead the neurocritical care multidisciplinary team upon completion of the program. Core of the fellowship: traumatic brain injury, ischemic stroke, intracranial hemorrhage, subarachnoid and intracerebral, status epilepticus, spinal cord injury, brain tumors and post-operative neurosurgical care, neuroimaging, interventional neurocritical care skills, endovascular treatments like thrombectomy and aneurysm coiling. The program provides experience with managing non-neurological critical illnesses as well. Neuroimaging, focused training in CT, MRI, interventional neuroradiology, exposure to endovascular treatments like thrombectomy and aneurysm coiling, neurology stroke services, acute stroke management, and advanced therapies like thrombolysis and thrombectomy. Topics also include neurophysiology, critical care pharmacology, multimodal monitoring in neurocritical care, post-neurosurgical interventions care, neurotoxicology, brain infections. Become a leader in neurocritical care. Join the fellowship. Save lives. Shape the future. Are you ready to lead in one of the most specialized and demanding areas of medicine? The Neurocritical Care Fellowship is designed to train you to manage critically ill patients with neurological and neurosurgical conditions. It's a wholly online, one-year American Association of Continuing Medical Education accredited fellowship. Physicians with critical care interest, intensivists, anesthesiologists, emergency medicine, family or internal medicine are qualified. Neurologists and neurosurgeons are also highly encouraged to join the fellowship to gain comprehensive, high-quality, well-structured education in neurocritical care. Fellows are expected to be able to lead the neurocritical care multidisciplinary team upon completion of the program. Core of the fellowship: traumatic brain injury, ischemic stroke, intracranial hemorrhage, subarachnoid and intracerebral, status epilepticus, spinal cord injury, brain tumors and post-operative neurosurgical care, neuroimaging, interventional neurocritical care skills, endovascular treatments like thrombectomy and aneurysm coiling. The program provides experience with managing non-neurological critical illnesses as well. Neuroimaging, focused training in CT, MRI, interventional neuroradiology, exposure to endovascular treatments like thrombectomy and aneurysm coiling, neurology stroke services, acute stroke management, and advanced therapies like thrombolysis and thrombectomy. Topics also include neurophysiology, critical care pharmacology, multimodal monitoring in neurocritical care, post-neurosurgical interventions care, neurotoxicology, brain infections. Become a leader in neurocritical care. Join the fellowship. Save lives. Shape the future.
Hello, everyone. Very nice seeing all of you today. It's very special day today because we are talking about very pivotal and very critical topic, which is the emergency neurologic life support. I think all physicians need to understand the importance of this emergency neurologic life support because ENLS is a standardized set of protocols developed by neurocritical care and emergency medicine physician to improve our patients' outcome. The ENLS guides healthcare providers through the first critical hours of managing our neurocritical care patients, especially those with strokes, status epilepticus, traumatic brain injury, and spinal cord injuries and compression. NLS provides a step-by-step approach during these golden hours when every second and every minute counts, and it guides the pest management and the precise treatment and interventions for these patients to improve the neurologic recovery, streamline the diagnosis, stabilizing our patient, and improve our patient survival. Also, the ENLS avoid delays in management, pitfalls, and errors. Today, we have diversity of speakers. Dr. Muhammad Mustafa from New Orleans, USA, Dr. Hend Mansour from King's College Hospital in Jeddah, Dr. Mostafa Gamal, who is a critical care physician in King Abdulaziz University Hospital, Dr. Bastiaan, who is a neurologist in King's Hospital, and Dr. John Thomson, who is an ER physician with a special interest in ENLS from King's Hospital, Jeddah. So again, it's very important to recognize symptoms and signs of all of neurologic emergencies and urgencies, including strokes, fainting, epilepsy, especially when it comes to patients who don't have grand mal seizures, patients with traumatic brain injury, which we are encountered more and more these days, patients with spinal cord injuries and compression, how to manage and how to diagnose them. Even headache, sudden headache, we don't usually feel it except we have it. And we have to exclude infectious process, especially meningitis, encephalitis, and brain abscess. So it's very important to understand these neurologic emergencies. In our neurocritical care fellowship, we elected not to teach you through lectures and reading, but to get you engaged and to have you actively participating in the e-learning process. Our neurocritical care fellowship is structured as 3 modules, 16 weeks each. So it's a wholly online 1-year training program. It's not based on monologue, but rather dialogue between the tutors, instructors, and the fellows. It's not only based on live webinar or virtual workshops, but also based on interaction and engagement of our fellows through giving them a lot of brainstorming and critical thinking materials with questions and answers, evaluation and assessments. So again, if you are interested in the neurocritical care field, I think this would be a very good opportunity. You can do it at your earliest convenience because we have a smart platform. You can log in whenever you have time and you can finish your tasks and assignments. And we have weekly quantitative and qualitative assessment and evaluation based on our fellows' performance. Upon completion of the Neurocritical Care Fellowship, you expect to be an expert in the field and to graduate from a trainee and a mentee to a trainer and a mentor level, and to receive graduation certificate from the American Association of Continuing Medical Education. Again, a whole year filled of lectures, journal clubs, MCQs, clinical case scenarios, and case-based discussion. The first module, which will be throughout 4 months, 16 weeks, will be mainly focusing on traumatic brain injury from classification, assessment, the severity of TBI, neuroimaging, ICP monitoring, and management strategies. In Module 2, we'll be focusing on acute cerebrovascular accidents from acute ischemic stroke, intracerebral hemorrhage, and subarachnoid hemorrhage. In Module 3, we will be discussing the core topics, especially focusing on status epilepticus, neuromuscular emergencies, EEG monitoring, neurotoxicology, pharmacology, neuroanatomy, post-cardiac care, and neuroprognostication. So today, again, very special webinar. Dr. Mostafa Gamal is going to give us some case-based discussion, and Dr. Muhammad Mustafa is going to take us in a journey with the ABC in neurocritical care management. Dr. Hend Mansour is going to teach us how to deal with unconscious patients. Dr. Bastiaan and Dr. John Thomson are going to deal with the discussion and help to answer the question with the speakers. Again, all of our educational activities have no value except we make it in practice. We apply this knowledge to our practice to improve our patients' care, because the great aim of education is not gaining knowledge, but to apply this knowledge, trying to improve our patients' neurologic outcomes, survival, and improve our standard of care. With that, I'm going to let Dr. Mostafa Gamal to share his screen and to walk us through some very interesting case-based discussion. Dr. Mustafa, go ahead, please. There is no sound.
Good evening, everyone, and welcome to our webinar on the Neurocritical Care Fellowship Program. My name is Mostafa Gamal, ICU physician at King Abdulaziz University Hospital. I am honored to be with you over the next 10 minutes, and I will briefly present 5 sample MCQs that reflect the type of questions you may encounter during the fellowship. MCQ 1. Which of the following medications has the highest increase in the context-sensitive half-life during a prolonged infusion? Ketamine, midazolam, propofol, dexmedetomidine, or fentanyl? I will give you a few seconds to answer. The correct answer is E, fentanyl. This is the explanation, but for the sake of the time, I will highlight only the most important key points. The context-sensitive half-life is the time required for blood or plasma concentrations of a drug to decrease by 50% after discontinuation of the drug administered by infusion. The half-life of fentanyl increases to over 300 minutes after an infusion of 5 hours. MCQ2, a 46-year-old patient with a cerebral aneurysm and a sister who died of a ruptured cerebral aneurysm is worried about her children having the same problem. She asks you about screening and treatment. What should you tell her? She should not worry about her children having the same problem. Her children should undergo a cerebral angiogram to rule out an aneurysm. CT angiogram of the brain once is enough for screening. The children should get long-term screening using MRA, or her children with aneurysm should be treated the same as the general population. Your answers, please. Correct answer is D. The children should get long-term screening using MRA. Key points here, we are discussing familial intracranial aneurysm screening and risk. Who should be screened? Individuals with 2 or more first-degree relatives with ruptured aneurysm as per ESO and AHA guidelines. And there is 21% aneurysm detection in the first-degree relatives according to familial intracranial aneurysm study. There is 17 times higher rupture risk with positive family history versus sporadic cases. MCQ3, a 58-year-old woman presents to the emergency department for throbbing headaches. She admits to not refilling her antihypertensive prescription. Her blood pressure on presentation was 200 over 120 millimeter mercury. She is beginning to demonstrate decreased mental status. Initial management should include an IV calcium channel blocker for goal map 110 millimeter mercury within 1 hour for hypertensive emergency, an IV beta blocker for goal map 90 millimeter mercury within 1 hour for hypertensive emergency, an oral calcium channel blocker for goal blood pressure 160 over 100 within 2 to 6 hours for hypertensive urgency, an oral ACE inhibitor for goal blood pressure 120 over 80 within 24 to 48 hours for hypertensive urgency, or an IV vasodilator like sodium nitroprusside for goal map reduction of 10 to 15% within the first hour for hypertensive emergency. Correct answer is A. This patient should receive IV calcium channel blocker for goal map 110 millimeter mercury within 1 hour for hypertensive emergency. This is the explanation, and the key points we should know that this patient has signs of hypertensive encephalopathy, which is considered a hypertensive emergency and for which an IV calcium channel blocker for goal map 110 within 1 hour is the most appropriate answer. The map decrease in this case is 25% within 1 hour. MCQ4, 62-year-old male was admitted with diffuse subarachnoid hemorrhage, intraventricular extension of the hemorrhage, and the early signs of hydrocephalus. An EVD was placed without complication. The EVD has functioned well, and the following placement, the patient's examination improved. The figure that follows is the waveform produced. What occurs during the B3 peak? This is the ICP waveform trace. B3 represents the arterial pulse. or B3 represents the cerebral compliance. B3 represents the respiratory ICP wave. B3 represents the dichrotic notch, or B3 represents the jugular venous pulse. This is a straightforward question. Correct answer is D. B3 represents the dichrotic notch. The key points here is that the above wave is a normal waveform that is produced during a normal cardiac cycle. The first peak found in the waveform is B1 or percussion wave. The second peak is B2 or tidal wave. The third peak is B3 or dichrotic wave. In normal ICP waveform, B1 should be higher than B2, which in turn should be higher than B3. Last MCQ, MCQ number 5. A 21-year-old male with no past medical history is brought in via emergency medical services for evaluation of a gunshot wound to the head. Police and EMS were called, and he was found at the scene awake, interactive, but confused. There appeared to be left frontal temporal entry site without an exit site. His initial vital signs were heart rate 136 beats per minute, blood pressure 95/54, and oxygen saturation was 98% on a 2-liter nasal cannula. His initial examination demonstrated an uncomfortable young man oriented to persons only, following simple commands with anti-gravity movement throughout his extremities, with some decreased movement on the right side. A head CT was completed. This is his CT, showing axial and coronal images. Which of these statements is most correct regarding penetrating head injury? Prognosis is better for penetrating head trauma than in blunt head trauma. Extensive debridement of the scalp and the bony wound should be undertaken, and accessible intraparenchymal bone and the bullet fragments should be removed. Antibiotic prophylaxis with vancomycin should be started. Retained fragments in eloquent cortex increase the risk of epilepsy following penetrating head trauma, or the subarachnoid hemorrhage demonstrated on the CT commonly leads to vasospasm and worse outcome. Your answers, please. The correct answer is D. Retained fragments in eloquent cortex increase the risk of epilepsy following penetrating head trauma. Key points here we should know is that penetrating brain injuries carries a worse prognosis than closed head injury. And there is long-term seizure risk is high. Around 50% may develop epilepsy within 15 years post-injury. Thank you all for joining, and see you next webinar.
Thank you so much, Dr. Mostafa Gamal, for this nice case-based discussion. Now we have the second speaker, Dr. Muhammad Mustafa, and Dr. Muhammad Mustafa has long journey and training, initially in Egypt, then he moved to United States and he finished his critical care neurology training in Texas, and now he's practicing critical care neurologist in New Orleans. And he's going to talk about the ABC management of ENLS.
Good morning, good evening, good night, wherever you are. It's very nice to join you today from the World Institute of Critical Care and Emergency Medicine. My name is Muhammad Mustafa. I was a neurocritical fellow for 2 years in University of Texas, Houston. I'm currently a stroke fellow at Ochsner Medical Center. So we're going today to delve into a very important topic, It's termed ABC in neurocritical care patients. We are going to enjoy talking about neurocritical patients when it comes to terms of airway, breathing, and circulation. What is common from the critical care standpoint, and what is different from neurocritical patients? And I would like to thank Dr. Amr El-Husseini and all the other committee members for hosting me today in order to participate. What I'm going to do, we're going to talk first to define who are the neurocritical patients that we mean. So, neurocritical patients are the neurologic patients who require close monitoring and close medical management. This is the simplest definition of neurocritical care patients. With this definition, acute ischemic stroke, intracranial hemorrhage, subarachnoid, intracerebral, intraparenchymal, interventricular, traumatic brain injury, mild, moderate, and severe, CNS infection, ventriculitis, meningitis, spinal cord infection as well, status epilepticus, brain and spinal cord tumors perioperatively, or if they develop cerebral edema and pre-compression, if they're coming for post-chemotherapy or post-radiation care, hydrocephalus, neuromuscular emergency, Guillain-Barré syndrome, botulism, and myasthenia gravis exacerbation. Coma, whatever the diagnosis is considered as a new critical care patient. And post-neurosurgical elective cases like complicated transspinal surgery or complicated brain tumor resection, all these patients are considered neurocritical care patients because they do require frequent neuro checks and they do require holistic management, which is beyond the scope of just one subspecialty or the scope of floor. And with setting the rules for the new critical care patients, we would like to give a special mention for herniation or brain cord people who develop herniation in the end of the lecture. Moving forwards, we're going to talk about what's different from the general ICU in terms of neurocritical care management. With that being said, in any ICU, your goal is to stabilize the patient hands in hands with figuring out the etiology and for the clinical exacerbation and treatment. However, in neurocritical care, we do focus on prevention of secondary brain injury, which means the inflammatory cascade that can happen as a result from the primary brain injury and can be exacerbated by hypoxia or hypotension or poor temperature management, things that could happen beyond the ICU. And this is what we are going to focus on today during the ABC, how to prevent the potential triggers for secondary brain injury. By airway, which is our first topic we're going to talk about today, we're going to spend some time talking about assessment of the airway, indications for intubation, intubation procedure, difficult airway management, and peri-intubation sedation. For airway assessment, the ideal and the gold standard scores that we all know is a Malapati score and the 332 score, which is basically counting the distance from between the two incisors, counting the distance from the tip of the chin to the neck, and counting the distance from the chin and neck junction to the thyroid cartilage, followed by assessment of the airway regarding the position and visibility of uvula and the tonsillar arches. And of course, the number when it goes from 1 to 4, it goes to the more difficult airway. So if I have a patient with grade 1 or grade 2 vocal cord view, I would be ready with the basic intubation kit stuff. However, if I'm expecting a patient who has a large and short neck, maxillofacial fracture, or a patient who requires to be head of bed up, like people who are crashing or are in brain code, when it's very critical, the head position matters. The lowering of the head of the bed can worsen the intracranial herniation. In this specific situation, in this specific population, it would be very important to have an additional set of instruments to ensure the success of intubation. And of course, intubation is not for everyone who has obtundation or altermentation or abnormal arterial blood gas in Neuro ICU. We would like to reserve the indication for intubation per the guidelines for people who badly need it. So the gold standard indications for ICU and neurocritical care intubation are reserved mainly for two big categories. The first and the most common reason for intubation in Neuro ICU is airway protection, which includes Glasgow scale 8 and lower, people with extreme bulbar dysfunction who can't protect their airway, and elective intubation in terms of long procedures, long neurosurgical management, or extensive neurological imaging in patients with compromised airway who deemed unsafe to do it. Also, respiratory failure, whether type 1 or type 2, type 3 or type 4, is one of the most common indications for intubation in Neuro ICU. And most of the time, when people are recovering from traumatic brain injury, ischemic stroke, or hemorrhagic stroke, despite their improvement in neurological outcome and consciousness, they may lag, however, in terms of ability to protect airway, and they may still have some sort of residual bulbar dysfunction. And with that being said, it would not be surprising to have people with these injuries who are recovering and, however, still keep aspirating, that they may require to be intubated. Also, hypoxemic population can be intubation candidate if they become non-responsive to the basic oxygen treatment, which is called the high flow nasal oxygen or the CPAP or BiPAP. And hypercapnic respiratory failure, as defined by respiratory acidosis and PaCO2, arterial pressure of carbon dioxide 60 millimeter mercury and higher, is one of the most common indication as well, in case they don't improve well with respiratory treatment and oxygen treatment, which includes patients with neuromuscular respiratory failure, patients with low vital capacity and depressed negative respiratory force. And numbers is not the great deal, but the great deal is how you observe these people in neuro ICU. You can have a patient with borderline respiratory mechanics. However, he is more awake, he's able to clear his way, he's heading in the good direction, his numbers are trending better. But you may have a patient who has good respiratory mechanics. However, as you do clinically get worse and despite getting treatment, and they may be deemed necessary for intubation. So again, intubation decision is a composite decision. It's not dependent on a single number or parameter. It's dependent on the overall clinical picture. And moving forward, we're going to discuss the basic intubation indications that we talk about. There is a step of sequences that we'd like to reserve the patient to before trying intubation. And the goal is to minimize the invasiveness of procedure. The basic simple thing, if a patient is not setting okay, is not saturating well, is to start with nasal cannula, which can provide from 1 to 6 liters per minute and fraction of inspired oxygen of 24 to 50%. And then you can use a simple face mask if still saturation is 92 and lower. A simple face mask can provide 5 to 10 liters per minute and 40 to 60% FI2. And if you're still not meeting the goal, you can try 15 liters per minute with non-rebreather oxygen mask, and it can include FI2 of 60% to 90%. And finally, there are two last results before intubation, which include high flow nasal oxygen, which includes from 10 up to 70 liters per minute, but in most places it's 40 liters per minute, and it can include FI2 up to 500, and CPAP, which we ideally would reserve for people with pulmonary edema or cardiogenic pulmonary edema, and high flow nasal cannula will be reserved more for people with hypoxic respiratory failure. For hypercapnic respiratory failure, people would like to have them on BiPAP. And of course, the big problem for BiPAP is the ability to protect the airway, since it's a very tight mask, needs to be applied in a good seal, so it may increase the risk of aspiration in neurocritical care patient if they are not awake enough to protect their airway. And with that being said, we'll move forward. Let's say if we try the oxygen treatment escalating from nasal cannula to non-rebreather to high flow nasal cannula and still not saturating okay, then unfortunately we have to intubate. There is a very important concept that the stereotype thinking we should crash intubate people, but the ideal way to do a successful and uneventful intubation is to pre-oxygenate neurocritical care patients before intubation. And the best way to pre-oxygenate is to have one of the aforementioned oxygen treatments applied to the patient while maintaining an open airway and having the charge nurse, the bedside nurse, a respiratory therapist, and you yourself, the medical provider, ready by the bedside, having every single thing regarding the intubation kits, the sedations, suppressors, paralytics, before you go ahead and intubate. After you achieve a very good pre-oxygenation, you can proceed with induction of anesthesia and neuromuscular blockade. And once you feel more comfortable that the patient has apneic oxygenation ventilation, there is no chest rise, you can go ahead and take a look. And in this way, you can prevent about desaturation and ensure that the patient doesn't have cardiac arrest or respiratory acidosis during the intubation. For the intubation procedure, you should be familiar with the intubation kit, which includes having glide scope. Of course, you have the direct laryngoscope, and you have the indirect, and you have the curved laryngoscope, we'd like to reserve the straight blades or the Miller blade for the anterior airways, and the curved air blades will be reserved for the classic airways, the grade 1 and 2 view. And in addition to that, you would like to have some sort of light, which is right here, and you can have the stylet, and you can have two different sizes of two sides types of endotracheal tubes. One of them is 0.5 millimeter smaller than the tube you are intending to place in case you find difficulty in inserting the endotracheal tube. And you will need a syringe to inflate the cuff once you secure the airway. You need a colorimetry to ensure that there's a color change after you secure intubation. You need a lubricant to make sure that there is a very good as avoid traumatic intubation. And of course, you may need a bougie in case the stylet doesn't work well. And it's not included in the picture, but you should have an ambo bag. You should have a suction method using the anchor catheter around. And always remember 4 people in the room, the provider, respiratory service, charge nurse, and the bedside nurse. And there should be a formal sign out during intubation. In positioning the head for intubation is very paramount importance. You should make sure that the pharyngeal plane, laryngeal plane, and oral plane are all in the same line to order to have a patent and easily visible airway and avoid unnecessary intubation trials. And the ideal way we prefer in your critical care setting is a ramp position, which means that the external auditory meatus is the same plane as the manubrium sterni, and in this position you don't have to hyperextend the neck. It will be just adequate enough to raise the head of the bed 30 to 45 degrees to make sure there is no intracranial hypertension during intubation and making the head as straight as possible. Let's say things did not go well, and despite doing the ramp procedure, you still cannot see the airway. You can reassess again, look externally, reassess with a Malabati score and 332 rule, check for obstruction, check for neck mobility in case of spine patients. And there are a lot of different algorithms, but to make them straight, the ideal way to tackle a difficult airway with having a second help, a second physician, or a second nurse practitioner, or an expert person in airway management beside you, and also to have the videolaryngoscopy with you, laryngeal mask airway, to have the bougie, and be ready for surgical airway management in case if needed. Peri-intubation sedation is very important and one of the misunderstood and under-recognized issues that we give sedation and we give paralytics for intubation, but we forget to keep people on some sedation after intubation. Intubation is a very traumatic event and it's a very painful experience. So you should be familiar with sedative agents that you have in your ICU. Each one of these sedative agents is reserved for a specific indication. Usually fentanyl is very useful as an analgesic rather than a sedative. Since it's an opioid receptor, and etomidate is a very good induction agent, especially in people with hemodynamic instability. And ketamine is one of the good brain-friendly sedating medication, especially with people with hypotension or cardiovascular collapse. And you should be familiar with the drawback, which includes visual hallucination, delirium, some sort of cardiac arrhythmia. And propofol is also one of the medications that can be used in induction. However, we would like to avoid in people with hypotension and shock, but it's very good in people with status epilepticus and seizures. And the same applies for the midazolam. It also has risk of hypotension, but it's a good indication for people with status epilepticus and also people with intracranial hypertension. For the paralytics, you can use the short-acting succinylcholine, or you can use something that's longer-acting like rocronium. But the gold standard rule, whichever paralytics you use in your critical care patient, make sure that your patient is well sedated before giving the paralytics, because it will be extremely painful to the patient to paralyze without having an adequate sedation. Breathing, which is the second item we're going to talk about, it includes oxygenation, ventilation, and monitoring carbon dioxide and CO2 control. So we should be able to tell the difference between oxygenation and ventilation. So oxygenation comes after ventilation. Ventilation is the passage of the air through the dead space in the airways until it reaches the respiratory and tremor bronchioles. And from there, the carbon dioxide will be washed out and then oxygen comes in. Once oxygen is in the alveoli and gets exchanged in the alveoli, here comes the oxygenation part and the gas exchange. So with that being said, we'd like to be familiar with the oxygen dissociation curve. So there is some sort of S-shaped relation between the partial pressure of oxygen and the oxygen saturation, which means people can tolerate certain amounts of hypoxia for a certain period of time as long as the arterial pressure of oxygen, which is a driving force for hemoglobin to take the oxygen inside the RBCs, down to PO2 of 60. But if the PaO2 is less than 60, the oxygen saturation starts to drop. So from here till PO2 of 60, you still have room to prepare your patient for intubation. And you should utilize it very well by pre-oxygenation to make sure you are not intubating at the tipping point, but rather you're intubating at the safer point. And coming back to the difference between oxygenation and ventilation, so oxygenation as a gas exchange is totally dependent on the partial pressure of oxygen that's coming, which is reflected in the FiO2 and the amount of oxygen, and also it depends on the functional residual capacity in the lung, which is exemplified by the positive index respiratory pressure in the mechanical ventilator. Ventilation, which is a washout of carbon dioxide mainly, is largely determined by the rapidity of breathing and by the tidal volume. Acute hypoxemia, which is one of the most common indications of respiratory failure, you should be able to approach it properly. So in order to approach it properly, you should be able to calculate the A to A gradient. And there are two kinds of populations that can have depressed A to A gradient, who are hypoventilation patients, like people with COPD and neuromuscular respiratory failure, people with high altitude, but most commonly people with elevated A to A gradient, they may either have a ventilation perfusion mismatch, they may have a shunt, or they may have alveolar hypoventilation. People with hypoxia who are responsive to oxygen therapy, they may have some sort of dead space problem, they may have an airway obstruction, impaired diffusion, or focal alveolar pathology. However, people who are poorly responsive to oxygen therapy, they may have some sort of lung or cardiac shunting mechanism, or they are hypoventilated badly. And in mechanical ventilation, like we said, you target oxygenation by the fraction inspired oxygen FiO2, and you target by delivering the good beeps that can maintain the saturation 92 and higher. And the determinant for carbon dioxide will be the respiratory rate, and it will be the tidal volume. And people who are freshly intubated, they would be preferably be on controlled or assisted ventilatory mode. And later on, from the ICU liberation module, you should be able to wean the sedation according to the ABC trial and wean them to the pressure support in order to liberate them from the mechanical ventilator and decrease the chance of ventilator-associated pneumonia. And when it comes to circulation, which is our last topic, we'd like to enforce and stress on importance of cerebral perfusion pressure, which is a product of intracranial pressure subtracted from the mean arterial pressure. It's very important to avoid hypotension and extreme hypertension in your critical care patient, in addition to balancing fluid management and temperature control. So as you know from medical schools, that intracranial pressure and cerebral perfusion pressure are very sensitive to carbon dioxide. So with that being said, increasing carbon dioxide will cause a vasodilatation, increase in intracranial pressure. However, lowering the carbon dioxide will, paradoxically, it can cause cerebral vasoconstriction. Ideally, you should target normal carbia to low normal carbia in pre-herniation. In patient with herniation, as you know, that hyperventilation is one of the modalities of treatment. However, it doesn't last long, and the kidney is smart and deals with a hypocarbia induction. And once you wean the partial pressure of carbon dioxide, the intracranial pressure may surge up again out of vascular dilatation. That's why it would be preferred to induce low normal to transient hypocarbia and then slowly titrating back the partial pressure of carbon dioxide to the normal goal. And for the blood pressure control, we know that a cerebral perfusion pressure, ideally 60 and higher, is the preferred goal. And the brain autoregulation can adapt very well by cerebral vasoconstriction in extreme hypertension up to 150, and with vasodilatation in hypotension. However, beyond these limits, breakthrough zone happens, and hypertension can manifest as present intercerebral hemorrhage, while in cases of shock, it manifests as a collapse. So we have to be very careful in terms of tailoring the intracranial pressure monitoring as it comes to blood pressure titration. And let's say if our people has hypertension and you are not sure that dropping the blood pressure may cause harm So that would be wise to titrate the blood pressure very gradually. Well, ideally in hypertensive insufficiency, we'd like to drop the blood pressure no more than 25% in the first 2 to 6 hours, or by less than 160 in the first 24 hours, and then toward the coming 2 to 3 days, we'd like to target normal tension. We would like to prefer nicardipine and cleviprex since they are faster kicking, have more predictable response and easy titratable, and would like to reserve hydralazine and labetalol for PRNs or required blood pressure control because of unpredictable blood pressure titration response and unpredictable onset of action, in addition to side effects such as bradycardia in labetalol and lupus-induced drug syndrome in hydralazine. For hypotension or shock patient, it's very important to maintain cerebral blood flow, and there is no specific treatment in critical care patients. The gold standard is to use norepinephrine. It has been the gold standard for clinical trials, and phenylephrine is a good choice as well. Vasopressin would like to be reserved for distributive shock as a second add-on pressor, dobutamine in cardiogenic shock, and epinephrine as pushes during cardiac arrest. Fluid management and balance is very crucial in your critical care patients. So you know that hemorrhagic shock can cause CNS symptoms and impair your critical care management, and it's a predictor of poor outcome. That's why I would like to target hemoglobin 7 and higher, and in some cases 8 and higher. And at the same time, you should be careful when you are transfusing products or reversing intracerebral hemorrhage, for example, not to exceed what you are doing so as not to induce a procoagulant state. So it's a balance all the times. Target temperature management is very important in critical care patients, especially in malignant cerebral ischemia and in subarachnoid hemorrhage with vasospasm. So ideally, it will target normothermia as evidenced by the target temperature management 3 trial. And brain herniation has the same graph as the oxygen dissociation curve, which goes in a nonlinear way. So the brain has room to comply for the increase of temperature until it reaches a tipping point, and then everything collapses. That's why you have to be proactive when you're trying to treat these people. And the proactiveness is by understanding the ways of brain herniation, whether they are subfalcine or transtentorial, which is the most common, evidenced by anisocoria and pupil change, and tonsillar herniation as evidenced by hyperventilation. And if you have an external ventricular drain or ICP monitoring, that would be ideal to monitor the normal ICP waveforms or intercranial pressure waveforms and to differentiate them from waves with intracranial hypertension when the beat wave is high, or if there is an increased pulsatility of transcranial duplex. All of these are non-invasive or invasive intracranial pressure tools, but most of the time you will not have them. That's why you have to rely on your clinical judgment, and you should be familiar with tiers of brain injury foundation practice to lower the intracranial pressure in brain herniation patient using the standard method like elevation of the head of the bed, neutralize head position, take off the C collar, control pain, sedation, control fever, trying to get a CT when able, call neurosurgery. If it's not helping, you can try hyperventilation or low normal PaCO2 and use hypertonic therapy using hypertonic saline or mannitol. You can try to place an EVD, and if not helping, then we get tubate for airway protection and starting the patient on sedation such as midazolam and propofol, like we said, and trying to use pressors if you need to go up on your sedation requirement, followed by neurosurgery and very rarely hypothermia induction and phenobarbital coma. And with that being said, I'd like to thank you everyone for careful attention, and I'd like to thank the World Institute of Critical Care and Emergency Medicine for giving me the chance to participate here today. Thank you.
Dr. Mohammed, thank you very much for a very, very interesting talk. If you're happy, we will take some questions on that talk just now before we move on to the next one. And if I can start, you mentioned about post-intubation sedation and the various drugs that we can use, but are there any drugs that you would recommend particularly for the induction of anesthesia in these patients?
So thank you first for your feedback. In intubation, there are a lot of randomized controlled trials as regard to the preferred induction agent. Usually, most of the time, would like to use something that doesn't cause hemodynamic compromise and doesn't drop the mean arterial blood pressure, so that to preserve the intracranial, preserve the cerebral perfusion pressure. So etomidate or ketamine are preferred agents. However, we have used midazolam many times as well in cases of status epilepticus. So the short answer is there is no number one drug of choice for induction of sedation. Always lead to the same, always lead to Rome. But what matters that if the intubation for brain herniation or brain cut, for example, one should make sure that you not drop the mean arterial pressure during intubation. So pre-oxygenation and maintaining augmenting MAP, that's a big goal for intubation. So whatever sedation agent that fulfills these two criteria, that would be the induction agent for choice.
Thank you. Thank you very much. Dr. Bastiaan, do you have any questions?
Yes, thank you for your talk, Dr. Mohammed. My question is, what is the target blood pressure in patients with like a hypertensive urgency?
Yeah, so systolic blood pressure or mean arterial blood pressure goal should be defined according to the type of neurocritical patient being treated. In cases of hypertensive urgency, which is defined as blood pressure greater than 180 over 120 without any target organ damage, would like to follow the GNC criteria. That is to say, by, like I said in the presentation, like dropping no more than 25% in the first 2 to 6 hours, followed by less than 160, and then later on the coming 2 to 3 days would like to drop to 120, 180. However, there are a lot of exceptions to this rule. It's not 100% like applied to everyone. So for example, if there is a patient with some suspected transient ischemic attack, would like to be on the permissive side, like less than 180 for systolic, for example. If there is a patient with suspected spinal cord injury, would like to augment MAP greater than 80, for example, in the first 5 days. Patient with intracerebral hemorrhage, from the INTERACT and the ATTACK trial, they have been to and fro talk, but the ideal is to preserve and limit the variability in the systolic blood pressure because it has been determined to correlate with the poor outcome. So ideally would like target 140 to 160 systolic. So each patient has a different titration agent, but the gold standard, if there is no target organ damage, we can proceed to treat the patient as hypertensive urgency as the usual GNC guidelines.
Very elaborate, thank you.
Of course.
One final question, Dr. Mohammed.
Sure.
Are there any special considerations that we should think about in brain injured patients that require intubation that may also have associated spinal injury?
Yeah, so that's a very good question. So one of the things that I forgot to mention in the presentation is people with cervical spine injuries. So people who see cervical spine injuries, first of all, they are mostly bradycardic and hypotensive representations. That's why you should be able to have some agent to reverse the bradycardia. In the same time, would like to have a sedation that can achieve analgesia and same time doesn't drop the mean arterial blood pressure. This one of the instances would like to use ketamine, for example, because it's a very good analgesic. Same time, it's more hemodynamically safe than the other agent like midazolam or propofol.
Excellent. Thank you very much. And thank you again for a very interesting.
Of course.
It gives me great pleasure to introduce my colleague from King's Hospital, Dr. Hend Mansour. Dr. Mansour is a consultant in emergency medicine with over 15 years of clinical and academic experience. She holds an MD and an MSc from Tanta University in Egypt and is certified both by the Egyptian and Saudi boards of emergency medicine. Her research interests include the management of polytrauma and metabolic coma, and it gives me great pleasure to introduce Dr. Hend.
Thank you. Let's start our presentation. Before we start, I need you to, sorry. So our objectives. Hi everyone, it's Dr. Hend Mansour, emergency medicine consultant. Today we're going to speak about how to deal with unconscious patients. So before we start, I need you to, I need you to imagine a patient is rushed into your department, no response, no history, and every second matters. So what will you do? And that's exactly what we will discuss today. Okay? So our objectives for today will be how to define unconsciousness from your critical care perspective, what to do and what is a systematic approach. It's time-sensitive emergency, so we have to recognize life-threatening conditions and initiate management. And it's also team-based care, requires coordinated efforts from all three. So at the beginning, what is the definition of unconsciousness? Unconsciousness is a state where a patient is unresponsive to external stimuli with no evidence of awareness. needs systematic approach. It's essential for rapid assessment, diagnosis, and management of unconscious patients. And as we said before, team-based care requires coordinated efforts from all emergency physicians, nurses, and critical care specialists. So, as you always hear, initial assessment, ABCDE, and as Dr. Muhammad said a very nice talk about it a while ago. So I will not go deep through ABCDE, but I will only say the headlines. So in any unconscious patient, you have to do systematic approach, which is ABCDE. A means for airway. As you always hear, initial assessment, ABCDE, and as Dr. Muhammad said a very nice talk about it a while ago. So I will not go deep through ABCDE, but I will only say the headlines. So in any unconscious patient, you have to do systematic approach, which is ABCDE. A means airway, breathing, circulation, disability, exposure. And for airway, we will be so superficial while talking now. خلاص, you have background from Dr. Muhammad lecture. So for airway, only assess patency, look for obstruction, protect cervical spine. For breathing, assess respiratory effort, check oxygen saturation. If ventilation needed, you have to do endotracheal intubation. For circulation, check pulse, blood pressure, capillary refill. For disability, GCS, pupillar response, and blood glucose. We have to do full exposure for full examination for injuries and temperature control. Okay. For airway, we have basic techniques, airway adjuncts, advanced techniques. From a neurocritical care perspective, use only suction if needed. Why? Because suction causes spikes in intracranial pressure. Okay. Also, from a neurocritical care perspective, in positioning, you need to do 30-degree head elevation with no contraindications, and maintain neutral alignment. Okay. Also, in case you needed intubation, propofol in vital stable patient is preferred agent because it will reduce intracranial pressure, will decrease cerebral metabolic demand, but the problem that it causes hypotension. So if you have a patient who is not hemodynamically stable, hemodynamically unstable patient, you will use atomidate. Okay. For breathing, check rate, depth, pattern, symmetry of chest movement, oxygen saturation, supplemental oxygen as needed. You have to keep saturation over 94, except in COPD patient, you keep it from 88 to 92. And neurocritical care perspective, avoid both hypoxia and hyperoxia, because oxygen free radicals are not so good. We need to target normocapnia. Okay. For circulation, you check pulse rate, rhythm, volume, blood pressure, capillary refill time, skin color, temperature. As you know, IV access, fluid resuscitation if needed. From your critical care perspective, avoid hypotonic solutions because they worsen brain edema. Okay. Also, special consideration. If vasopressor needed, norepinephrine is preferred because it maintains mean arterial blood pressure and less tachycardia. We are speaking from neurocritical care perspective. Okay. Avoid dopamine because it increases intracranial pressure and causes arrhythmia. Then we go for neurological assessment. Here we go for the GCS. The standard tool for assessing level of consciousness. It evaluates 3 components: eye opening, verbal response, motor response. Eye opening, 4 is the best response to spontaneous, 1 to no eye opening, verbal response, 5 to oriented to time, place, and person, and 1 goes to none. Motor response, 6 when patient obeys your command, and 1 goes to none. So highest score in GCS is 15 and lowest score is 3, no 0. Okay? And then another thing in GCS, you take best response. Okay? So when you are evaluating a motor response, one side is 5, other side is 4, we take 5. But put in consideration the difference between 2 sides. But when you write your score, you will take the best score. Okay? And then after GCS, you have pupillary assessment, size, symmetry, reactivity to light, blood glucose, essential to rule out hypoglycemia. And as my senior told me when I was a young resident, when GCS is 8, you have to intubate, okay? So the integration of ABCD in neurocritical care, in summary, airway, you have to secure airway without raising intracranial pressure, breathing, maintain normoxia, normocapnia, avoid ventilator-induced intracranial pressure rise. For circulation, maintain perfusion, avoid hypotension, individualize blood pressure goals depending on pathology. So we need to ask ourselves, is it important to get final diagnosis before you start resuscitation? Of course not. Okay, we'll speak about this later, what to do. So what might be the causes of unconsciousness? It might be neurological, metabolic, toxicological, cardiovascular, and so on. So I will only mention the neurological, and the others, it's all on the screen. It might be stroke, ischemic or hemorrhagic seizures, intracranial hemorrhage, traumatic brain injury. Okay? And then when you are dealing with unconscious patient, you have to put in your mind that we have to stabilize our patient. And in the background, we are doing assessment to know what is the possible cause. Why? Because it's also important to know the cause to individualize your treatment. But it is not important to know it before you start your treatment. You have to stabilize your patient first. It's your priority. So our management principles to stabilize, diagnose, treat, protect, monitor, escalate. So for stabilize, you have to secure your airway, ensure adequate breathing and circulation. Regarding diagnose, rapid assessment for reversible causes like hypoglycemia, like opioid overdose. Treat, assess underlying cause while providing supportive care. It's major point and very important. Prevent secondary brain injury through positioning, temperature control, maintaining normocarbia, normal level of oxygen, maintaining mean arterial blood pressure, and so on. Okay. Here comes monitoring, continuous assessment of vital signs and neurological status. Then escalate, you have to do early involvement of senior clinician and the critical care team. It's so essential. Okay. So when we go to monitoring of our patients, unconscious patient, you have to do continuous monitoring for vital signs, heart rate, blood pressure, respiratory rate, saturation, temperature, and for neurological status, including GCS and pupillary response. And don't forget to measure your random every now and then, okay? And then for your supportive care, for this patient, we have to do positioning, 30-degree head elevation if no contraindication, temperature control, prevent hyperthermia. We can use what's called targeted temperature management. It has individualized situation, and it's not our scope today. Also, don't forget eye care and oral care. Okay. So, any questions? So, to wrap up, unconsciousness is a time-sensitive medical emergency requiring immediate systematic assessment. ABCDE approach provides a structural framework for initial assessment and management. Glass coma scale is essential for neurological assessment and monitoring. Early identification and the treatment of reversible causes improves outcome. STEAM-based approach with early senior involvement is crucial. Thank you.
Thank you very much, Dr. Hend. That was a very interesting and thought-provoking talk. If you're happy, we'll take some questions now.
Sure.
You mentioned that hyperoxia can be dangerous in these patients. Could you elaborate on that, please?
Yeah, because in the past we deal with oxygen like it's treatment for all issues and it has no side effects. But later on they discovered that oxygen, when you give it more than needed, it has free radicals that cause damage already to the tissue. So it's not good to put oxygen for the one who need and don't need.
Thank you. Thank you. Dr. Bastiaan, over to you.
Yes, thank you, Dr. Hend. Very interesting, especially for me as a neurologist. And I'm looking into the panel with the questions, and one is, it's actually in Spanish, but I think I might be able to translate it. And the participant is anonymous, but wants to know about the 4 score. Are you familiar with that?
Want to ask about what?
The 4 score. The 4 score for patients with traumatic brain injury.
No, I'm not familiar with that one.
No. You, Dr. John?
No, I must agree with Dr. Hend. It's not something that we use in emergency medicine regularly.
No, neither do we in neurology. And Dr. Hend, I have a, I think, important remark that if you have like the comatose patients who comes from the street, so to say, and if you administer glucose, especially in countries where they drink a lot of alcohol, like in Europe or the States, it's very important that you always give thiamine first. Because if the patient has a relative thiamine deficiency, you might induce a Wernicke encephalopathy by just giving the glucose straight away. So I think that's an important remark for our listeners. And then a question from my side is about that number of 8 for coma. That's very arbitrary, that below 8 you should intubate. And is that still valid? Do you agree? Do we need to intubate all patients with the lower scores, or like with a score of 6 or 7, you might also see for close observation? What's your opinion on that?
Yeah, when GCS level reach 8, we lose all protective airway reflexes. So we need to intubate not for oxygenation or ventilation failure. No, it's for protecting airway. No more protective airway reflexes, so patient will aspirate and eventually will have respiratory failure.
Yeah, so you would say you always should do that in the score below 8. That's intubate. That's not something to negotiate.
Very
No.
valid.
Okay, wonderful.
Okay, thank you very much. I just want to say thank you again to all our speakers, Dr. Mostafa, Dr. Mohammed, and Dr. Hend, for 3 very different and interesting talks that feed into the fellowship in neurocritical care. I think these talks have shown why ENLS helps healthcare providers manage patients, as Professor Amr said at the start, in the critical first few hours of emergencies such as stroke and status epilepticus. And finally, I'd just like to remind those that are consider registering for our fellowship, there are links in the chat box that will take you to the Institute's website with more information, and there is a 10% discount link included in the chat that's valid for the next 2 days if you're currently interested in registering for that. Thank you for your time and for attending this evening, and have a good evening. Thank you. Good night.
Thank you. Bye-bye to all.
Thank you.
Thank you. Bye-bye.